Hi, my name's Amelia Lyons, and I'm running a short video for you on a moral injury, moral pain, and moral distress. And in this, we'll look a little bit more closely at how this works in particular in the health professions, but it will also apply to other caring professions. So let's take a closer look. So moral injury, although it deals with an age-old dilemma for human beings, was coined by Shay in 1999, first of all, and then subsequently. He was a psychoanalyst who worked with veterans over a 30-year period, and he talked about it in relation to leadership, being a betrayal of what's right by someone who holds legitimate authority in a high-stakes situation, high stakes being life or death, or serious or lasting damage is likely. And he focuses on the need for leadership to be expert, ethical, and properly supported. So whilst Shay's definition focuses on leadership, Litz's definition tends to focus on the self more. The idea that you may have done something or you may have not done something that's failed to prevent something high stakes, or that you might have witnessed an act that has made you feel very uncomfortable. And in both cases, you might feel the moral injury at the time, or you may feel it later, depending on the consequences of the actions. Now, both of these definitions are fairly comprehensive, but it's also, I don't think that they cover quite enough here. And we'll look a little bit around at moral distress and moral pain to look at the area a bit more broadly, especially as it appertains to health. So the BMA, British Medical Association, talks about and makes a distinction between moral distress and moral injury. And so what they say is that the moral distress occurs when individuals can't follow through with what they believe to be right because of organisational, institutional constraints, notably staff and resource constraints, those kinds of things. And then they talk about moral injury almost as being on a sort of a gradation here, gradation higher, where it occurs where you may have one or more exposures to morally harmful events occurring, leading to deeper psychological and existential wounds. So this is kind of partly relates to, I think I'd further expound on this, death by 1,000 cuts. You know, that people in the NHS are exposed to a constant round of resource cutting. So in any civilised society, we ought to be prepared to take care of each other properly. In most cases, we really know how to take care of each other, but we don't necessarily have the resources made available to us to deliver that care to a degree at which we feel comfortable with. So I would argue that staff, hospital staff and health staff are constantly being exposed to moral injury through not having sufficient staff and sufficient resources to care for the people that they're working with fully and to the degree that they deserve and need. So I think we're in a permanent low-level state of moral pain about this, which may from time to time rise to distress and injury depending on the stakes at hand. And sometimes those stakes aren't always obvious. If you imagine a client on a waiting list for counselling or psychology being told they've got to wait a year, even longer. Now, some clients, we know from research, actually get better being on the waiting list, but we do know that some get worse and some may end up killing themselves or doing damage to others, where if they'd have been seen sooner, that might have been avoided. And they may have caused lasting damage to others, and we see this from time to time on the news and so on. So, but those are extreme situations. But as I say, at an ongoing low level, I'm reminded of the image on YouTube of the buffalo, a huge, beautiful, majestic animal being brought down by the hyenas. You know, it's gotten separated from its herd. You look first of all at the buffalo and you think there's no way those hyenas can take the buffalo down. But, you know, steadily and steadily and steadily, the buffalo is brought down by the persistent hyenas. And I think of the hyenas as governments making cuts, constant cuts, where cuts shouldn't be made, and ultimately the workers and the patients in those situations might represent the buffalo, depending on the context. So let's look at the impact of moral injury and moral distress in the subsequent slides here. Now, I just want to draw a brief reference to the artwork that is accompanying these slides, you know, the pictures here. And these are from an exhibition in the Towner Art Gallery in Eastbourne called Drawing the Unspeakable, curated by David Dimbleby and his either wife or daughter, Elizabeth. So it's something that I saw quite recently, and I took photos. I took the photos to go with this presentation. So I just want to acknowledge that. And I also want to say that, yes, that when you're psychologically damaged and injured, it can feel pretty unspeakable. It can feel extremely hard to talk about. So that is one of the first ways in which it affects us. And when we feel like that, of course, and we don't talk about it, then help is going to be difficult to get, because people don't necessarily, they might know that there's something bothering you, but they don't know what that is. And it's too early for you to be able to talk about that yet. So you're giving off signals that indicates, don't touch me, you know, don't talk to me, you know, I'll speak to you when I'm ready, sort of thing. So that's the unspeakability, but feelings sort of underneath and around and about that: guilt, shame, failure, betrayal, anger, and moral disorientation. Again, it will depend on the context and what's happening. But it's also kind of tied up with our identity, that we can get very tied up with our roles. I'm Amelia, I'm a nurse. I'm Amelia, I'm a psychotherapist. I'm Amelia, I'm a teacher. And when we identify very strongly with our roles, and then due to the injurious situation, our view of ourselves in role may get fractured, broken, shattered. And if we're very strongly identified with the role, then of course that can really affect us. So that's something to also be aware of. There is how attached is the person to their role, and if that's extremely important to them, chances are that the level of injury may be felt even more acutely. It can lead to impaired psychological functioning and harm for patients, and the BMA agrees with that. And whilst it's not officially a medical diagnosis, Sophie Redlin has argued that it does lead to symptoms such as depression, burnout, suicidal thoughts. Rosen talks about it leading to burnout as well, and accounts for very much a proportion of the mental health problems facing the NHS today, not just staff. Now here, drawing from Shay and Redlin, we can really see how it might change people. We've just talked there about depression, burnout, suicidal thoughts. It impairs and may destroy trust, elevating despair, suicidality, violence, and we know this from when we look in particular at veterans research. It deteriorates their character, ideals, and ambitions. I mean, that's a major issue there for people. It changes and shrinks attachments, and we know from other research that relationships are so important. The human connection factor is so important to the continued survival of the individual and thriving and well-being. People become lonelier and more withdrawn. And it may result in a settled expectancy of harm, exploitation and humiliation from others. That might be something like a classic bullying situation, where the person just tolerates it, and then that's their expectation of this is what it's like. Or it might be in NHS something like where you're constantly exposed to a lack of resources, and there's a sort of an expectation really that we can only do this and no more for people, even though it's kind of going to the lowest common denominator, and then having very low expectations when actually our wishes for our patients ought to be higher and ought to be of a good standard. So in all cases, Rosen talks about moral injury rupturing self-identity and leading to feelings of guilt, shame, and social withdrawal. So, some examples of moral injury in the health professions, and you could also think about it in other caring professions as well. So in health, both physical and mental health, we're looking at decisions which might result in life or death outcomes for patients. So in physical health, it may be critical care and allocations of things like ventilators and other life-saving equipment where there isn't enough of it. So you're having to make decisions about who gets what, who gets the oxygen. And in mental health, it might be who gets the bed, and leaving some mental health patients not getting a bed, and they might be a danger to themselves or others. So that's also life or death. Similarly, waiting lists can, at their extreme examples, also lead to that kind of thing as well. So Hobson's choices, meaning that whichever choice you make, it's a kind of lose-lose outcome. So that's something that's hard to bear, constantly doing that. Policies leading to a sense of betrayal. So the classic one in COVID, not allowing people to be with their loved ones when they were dying. And that's leading to a sense of betrayal, even though that may make a sort of logical sense. It's as far as the bereaved are concerned, that isn't okay. Experiencing betrayal by leaders, so leaders making perhaps decisions to make budget cuts in one area over another, or governments making budget cuts to, say, health as a whole, leaving it to senior management to then make decisions about where to implement those cuts in hospitals. So again, there's a sort of sense of betrayal from the top down, leading to sort of down at the bottom there, prioritising one patient over another, or prioritising your group of patients over your family, or the other way around. Either way, leading to sort of feelings of feeling intensely torn. Again, in pandemics and extreme situations, witnessing and treating more death and suffering than expected, so kind of an exhausted, overwhelmed feeling there. So lots of situations like that where we're feeling powerless to confront a situation, feeling powerless to increase budgets where we can see that needs to be the case. Implementing decisions that leave you feeling that you're very torn. So all of these things and many other areas of examples of moral injury in the health profession. So again, just revisiting really, what is it that distinguishes, say, moral pain and moral distress from moral injury? We looked earlier a little bit at the BMA, drawing a line there. What are other morally injurious situations, that we will suffer from? So where the stakes are not quite as high as life or death, or lasting psychological or physical damage, but damage that nevertheless may be lasting over a number of years, for example. So that could be in examples of extramarital affair on both sides, feelings of betrayal, guilt, shame, etc. For example, having a family member who is abusing substances, misusing substances or alcohol, and possibly stealing from family and friends in order to support the habit, and feeling very hurt about it if you're on the receiving end of that, or if you've been the person doing it, living with that guilt later, perhaps in recovery. Turning your back on a friend in need, destruction to property, that's often a sign of feeling angry about something, lying or cheating in ways that damage relationships and violate community norms. So all of those can lead to feelings of betrayal and suffering. But it's the high stakes that is the marker for moral injury. But I think it's important to recognise that we can all feel wounded and in pain morally, and will do somewhere in our lives. So, and it depends on the individual personality as to how long-lasting and wounding those effects might be. And depending on your other resources that you've gathered in your life and other supports that you have, these things may be more or less enduring and painful for you. So the purpose of this slide is simply to point out that the system, such as governments, such as senior managements, make decisions about how resources are organised or deployed, and then working down to senior, and then organisational management, junior management, and eventually the health professional at the front line, who turns the patient away or, makes the decision to either refuse the patient treatment or give them a treatment that they might need more of, or put them on a waiting list, or so on. So it's that health professional at the front line who bears the brunt of the decision made by the system, if you like, as a whole. So you can see those arrows going down there in the diagram. It's the individual who takes the brunt of that, who experiences perhaps an angry person who's not getting the treatment that they want or need or deserve. It's the individual who's receiving the battering at the end of that, and who's feeling very, very torn and uncomfortable with having to make these decisions. So that's the issue there, is that organisations don't have feelings, systems don't have feelings, governments, as a whole don't have feelings, but it's the individual human being that has the feeling, and it's that person on the front line who's getting the flack. It's important to understand that. So quite a useful way of understanding some of the emotions wrapped up in moral injury. Evans et al. In the moral injury workbook drew up a table here, moral emotions, causes and outcomes. And looking on my right there, the first two, guilt and shame, are self-directed emotions, and then anger, contempt, disgust and hatred are other directed emotions. With the guilt and shame, for example, those might be examples of decision that you may have participated in that later caused moral injury and wounding. For example, putting a patient on a long waiting list rather than treating them straight away, turning them away from a hospital bed rather than treating them straight away, be it mental or physical, and then the patient has subsequently died, killed themselves, maybe killed or harmed somebody else, and then you're kind of left there feeling ashamed, guilty, very torn about what's happened. So although powerless as well, that you didn't have the resources to offer, that nevertheless, as we were saying, that it's the individual at the end of the system there, and they're the ones carrying the flack. And that may result then in a kind of withdrawal, isolation, disconnection from others, There may be some reparative actions taken if it was a situation in which the individual made a poor decision rather than it being a sort of resource-based issue and driven by that. So sometimes there's ways in which, of course, things can be done to improve a situation. But sometimes it may simply be as a result of those resource-based decisions being very difficult to then implement. Then there might be other examples of other directed emotions, for example, where you might have been on the receiving end of for example, say, severe bullying in the workplace, and feeling angry about it and hating the person who's bullied you. There might be situations where I heard of about a woman, in the investigation of surgeons, where one surgeon in surgery mopped his sweaty brow on the woman next to him, whether she was a nurse or a junior surgeon's breasts, wiped his head on her breasts and made some kind of humiliating remark, and nobody said or did anything in that situation. But it sort of surfaced many years later when this was being explored in terms of issues in surgery to do with women and struggles there. Then you've got situations, for example, let's take apartheid in South Africa, where terrible decisions were made and people were killed in defence of an indefensible policy and practice, so desecration of really important things, death of Steve Biko, those sorts of issues, and feeling an absolute disgust and hatred with the people who implemented apartheid. Now, there can be some constructive things to come out, such as the Truth and Reconciliation Commission that set up by Mandela and so on. But there can also be some enduring sort of feelings of hatred and aggression resulting from such behaviours. So it's worth thinking about the issues that you may have either participated in or received and felt wounded about, and looking at those mix of emotions there and thinking and trying to plot where you are with those currently, thinking about that. Then Shay, in the treatment of veterans, talks about some clinical challenges of working with moral injury, things like secondary trauma, being made witness to atrocities and depravity through repeated exposure, i.e. when you're treating the veterans and you're exposed repeatedly to this. Assignment of survivors' transference roles to clinicians, so you're going to receive as a clinician a fair bit of battering there, as in you're an authority figure and you're going to receive both positive and very negative transference in relation to past experiences. And likewise, you'll experience counter-transferential feelings that go into the relationship that need to be dealt with. So you need intensive, excellent supervision within all of that to be able to manage and handle these issues in therapy. Okay, so how to treat moral injury. Let's get stuck in. Yeah, so one of the themes of moral injury, as we talked about before, might be feelings of shame and guilt tied up in the process. Those can keep you silent. So the first thing is it's important to share experiences to enable that to happen. And Shay talks about healing taking place in particular in community. Talk about that in a minute. Other issues tied into that are the idea of professional identity. If you're strongly identified with being a nurse, a soldier, a health professional, a clinician, and so on, and these are sort of fairly core to your identity, when that's kind of comes under threat or gets fractured, that can be very traumatic. And then thinking about the idea of being able to forgive oneself, forgive others, and what that might mean in practice. So, doing some work in those areas, obviously, encouraging a safe holding space. So, some of this is very similar to working clinically generally. But perhaps there are specific areas that we need to particularly bear in mind. So zoning in then on self as role, self as concept, and the whole self. So as I was saying, we can get very invested and attached in our roles at work. And they may become a major part of our identity, and we may find it difficult to separate those from our overall selves. So one way I think of it is if we think of ourselves from 0 to whatever age we are now as a kind of a tree in that sense, and that tree reflects your age. And then the branches being the roles that you hold, for example, as a nurse or a counsellor, role as a mother, role as an aunt, role as a lay preacher, role as an amateur artist, role as a poet. We have many roles that we may hold in the lives that we have, and these are also ever evolving. But if we're strongly identified and strongly sort of diligent, conscientious in the workplace, chances are we're going to be more severely affected. People can feel broken in roles, and it's very important, therefore, the work to look at the work in terms of one's whole overall identity, and that the role is not all of you. So there's work that can be useful work that can be done on that. Now, Shay's work is interesting with veterans. I particularly like the idea of recovery in community. So he looked at the idea of supporting and fostering those veteran bonds, and basically group therapy and group work with individuals, with soldiers and so on, in small groups, and that would also re-establish sort of social connection and ability to talk about things with people who you feel understand you to begin with. And as that recovery happens in that understanding group, so you're stronger then to go out into society ultimately and be more social there as well. Within that, you need, as Shay says, a kind of a working team, a working clinician team that are also a tight team and a tight group. Lots of peer supervision going on there and expert supervision, kind of reflecting each other really. So one reflects the other, and that it's a creative holding clinician team that will then hold a creative group. So it's kind of important that both groups work very strongly together to help in the recovery process. So leadership is never more important. It needs to be supportive. It needs to be ethical and empowering. And that's quite a challenge to sustain over a long period of time. So the news isn't all bad in this respect. There are really positive things that can come out of the most negative of experiences. I mean, what could be more morally injurious than Nelson Mandela, for example, 27 years in jail for objecting to apartheid rule, and being locked up, and his, the large part of his adult life being stolen away from him. But yet he spent the time in jail, talking with other ANC leaders, Walter Sisulu and other people, about developing a post-apartheid state in South Africa, coming out, leading the country, a total inspirational figure, really, from the worst of experiences there, surviving that. If we look at a more recent example of, say, Chris Hoy, and his recent diagnosis of terminal cancer, Stage 4, he's got a couple of years, he's not sure how long, but wanting to go on TV and help people to talk about these experiences and get earlier diagnoses so that they can survive and so on. So things can come out of the most adverse of circumstances. We might not say that the cancer is morally injurious. We might say that the act is inspirational. And people can be inspiring. Let's think of Simon Weston, who had terrible burns from the outcome of war, and again, the sorts of inspirational things that he's done. So in all of these cases, these inspirational figures incorporated their experience into helping others, setting up new systems and so on, which then help to ensure that the systems are much better and people don't need to go through quite the same thing again. Now, that isn't always the case, of course, and not everybody is an inspirational figure or wants to be. But on a smaller scale, we might say that we learn from these very, very painful experiences, and if we put our minds to it, can gain insight and become stronger and better as a result of that. And there's some evidence to indicate that that does actually happen. So, concluding thoughts and recommendations. So again, we're back to Shay's argument about leaderships being ethical, expert and properly supported, which on all too few occasions happens. In other words, that needs to happen a lot more time than it currently does in most situations. Sometimes you can have good leadership for a while, but it doesn't seem to be sustained quite often. That's true in governments, and that's true in often organisations as well. So that is something that needs to be constantly worked on from the top down in order to improve situations for everybody. Then sort of normal things in relation to developments and helping people, working with people, which is having areas to encourage help, noticing when symptoms aren't naturally resolving on their own, having good communication going on, having good resources available to help people. I think both the BMA and the LCN can see that there is an ever-shrinking workforce with retention being very difficult. So that when people are subject to inquiries and stressful situations which really weren't originally of their making, but somehow they end up being the targets of, then this threatens retention in an already shrinking workforce. So they recommend that systemic work should be done to address the issues more fundamentally, and interventions and lots more support needs to be available on the front line. I think with the BMA is their recommendations are not systemic enough, that they talk about the benefits of support networks and developing a sharing and open workplace culture, but of course in practice that's quite difficult. You really need a very strong system to support that. So I would support the BMA recommendations, but I'd want to see more than that. Again, RCN makes some quite good individual recommendations, which I'd say should apply to the workplace as a whole generally, not just in cases of moral injury and moral pain, which anyway the health service is constantly dealing with. So talk about staff well-being, leave, rest, recuperation, mechanisms in place to bring issues of concern up. Well, we know all that, of course. That's already strongly recommended and not enough of it is provided. And then we've got some systemic recommendations here from the RCN, which is, I think, slightly better than the BMA, actually. Occupational health services, employers, needing to recognise all of these signs and really finding and funding sufficient resources to support the staff. And staff needing to be able to raise concerns easily, and the professional voice really being listened to, as opposed to, say, a managerial voice that doesn't recognise the clinical issues that staff are really facing. So lots of resources, as usual, online for people to look at, recommended in this presentation. And also you will see references in the next page as well. So plenty of things that can be looked up and thought about in relation to self-care. And at the end of the session with Amelia's moral injury days, certainly if there's more that you want to talk about in terms of your own self-care, very happy to talk to you further about that face-to-face, one-to-one, to explore your options. Thank you.